Hi, my name is Kendra Foreman, and I am going to talk about my process improvement project, the effectiveness of suicide prevention using the Columbia Suicide Severity Rating Scale assessment instrument as an early intervention screening for suicide severity. Within the last 15 years, suicide rates in the U.S. have heightened. According to the CDC, suicide rates peaked in 2014 to 13.0 cases per 100,000 compared to 1999, where suicide rates peaked at 10.5 cases per 100,000. Suicide is receiving significant attention as a huge public health concern. Due to the significance of suicide, depression screenings for suicidal intent and ideation has been endorsed for periodic primary care visits, psychiatric outpatient clinics, and emergency departments. According to the CDC, suicide has claimed nearly 45,000 lives and is the 10th major cause of death in the U.S. The Joint Commission recognizes suicide to be sentinel crisis in the psychiatric population. The National Institute of Mental Health describes depression as the most prevailing mental health condition and the third leading root cause of mortality among young adults. Major depression is the most common mood disorder in those who attempt or complete suicide. Suicidal behavior often accompanies major depression disorder, and when left untreated or undiagnosed can lead to an increased risk for suicide. The purpose of the Suicide Severity Screening Project is early recognition of suicide in patients with major depression disorder symptoms and to provide proper referral for those who screen positive for suicidal thoughts. The aim of my project is to improve identification of suicidal ideations and behaviors and to reduce suicide through administration of the PHQ-9 for depression and suicidal risk and to validate suicide severity with the Columbia Suicide Severity Rating Scale. Now let's look at the methods used for my process improvement project. There are 85 young adults aged 18 to 29 chosen from a convenience sampling. Inclusion criteria were adults aged 18 to 29 diagnosed with major depressive disorder. Exclusion criteria are participants less than age 18 and older than age 29 with prior suicide attempts or plan and currently seeing a therapist. The setting took place in an outpatient clinic located in Colton, California. Now let's talk about interventions. The PHQ-9 is a highly reliable 9-item depression scale used throughout the country to evaluate symptoms of depression that were present in the last 14 days. The items of the PHQ-9 are used in congruence with the Diagnostic and Statistical Manual version 5. Diagnostic criteria in relation to the depressive symptoms and suicidal ideations. Positive screening on the PHQ-9 on item 9. A positive screen is any number greater than 0. To further validate a positive suicide screen on the PHQ-9, the CSSRS was utilized to screen for suicide severity. The CSSRS can be used in numerous settings to include schools, primary care, hospital-based clinics, and law enforcement agencies. The CSSRS is a detailed assessment used to further assess duration, suicide ideation, lethality, and behaviors. The PHQ-9, item 9, was evaluated using the CSSRS. The CSSRS also includes a risk assessment checklist that is completed by the provider following the patient assessment, consultation with other professionals and family, and a review of the patient medical record. Now let's talk about data collection and analysis. All young adult patients aged 18 to 29 diagnosed with MDD seen in the outpatient mental health clinic were asked to complete the CSSRS in addition to the PHQ-9. Both forms were completed prior to the initial scheduled appointment and at each follow-up appointment. Data for the reported analysis was collected from outpatient visits over a period of 84 days. Now let's look at the results. Prior to implementation, there was no suicide severity screening performed in the clinic. After implementation of the CSSRS, 59% or 50 of 85 patients were identified at an increased risk for suicide by the CSSRS. 4 months prior to implementing the process improvement project, there were numerous gaps in detecting suicide severity in numerous patients. Although the PHQ-9 was used to detect and diagnose major depression, it did not effectively detect suicide severity, which increased the number of incidents in this population due to the lack of proper referrals and support. During the process improvement project, 50 patients screened positive on item 9 of the PHQ-9 and were identified as being at an increased risk for suicide behavior. Of the 50 patients identified with increased suicide behavior, 30 screened positive for suicide ideations with recent suicide behavior or intentions of acting and were referred to adequate resources for continuation of care. In addition, clinicians showed great improvement in identifying suicide severity and making adequate referrals during the project. The results of this quality improvement project demonstrated use of the PHQ-9 suicide question increases awareness in the identification of the severity of depression. The CSSRS also increases awareness of suicide severity, which further helped identify recent suicide behavior, suicidal ideation, and the degree of intent to act on attempting suicide. Although there were limited resources and low number of participants, as well as cancellations and no-shows, the results of this process improvement project showed significant information suggesting that the CSSRS assessment instrument for detecting suicide severity is an adequate assessment instrument when used with the PHQ-9 suicide question for detecting those at risk for suicide. When used together, the CSSRS and the PHQ-9 validate suicide risk, suicide ideation, suicide behavior, and suicide severity. Practice implications. The psychiatric mental health nurse practitioner is able to provide adequate support and referrals in the practice setting in which the process improvement project is implemented. The project is a prime example of how valuable and important it is for early detection of depression and suicide severity in the chosen population diagnosed with major depression. Below is a table of implications for practice for desired outcomes. Prompt depression screening and diagnosing using the PHQ-9, early detection of depression and suicide severity in young adults diagnosed with major depression disorder. Provide proper referrals for those who screen positive or who are at high risk for suicidal ideations and thoughts. Future recommendations. Healthcare and mental health providers must recognize the relevance of constructing a robust therapeutic alliance with depressed and suicidal patients. Results suggest that the CSSRS is an acceptable instrument for assessing suicidal ideation and risk. Utilizing consistent instruments of measuring and assessing suicidality will be very useful for further studies. And here are just a few references used throughout my process improvement project.